it was just,
Yes.
am I mute? Yeah, you were right. But it took a while for you to get the loop right.
Okay. Thank you so much.
Thank you. Do we have candidate number 3 with us?
Yes, ma'am.
Okay. I'm going to give you a chest X-ray again. Okay. This is a routine clinic chest X-ray for a patient who's come in for follow-up.
This is a frontal radiograph of the chest of a mature skeleton. At first instance, I see there's no pneumothorax, pneumomediastinum, or pneumoperitoneum. I see that there are bilateral opacities in the upper zone and mid zone. They are appearing to coalesce, and they are appearing to be more in the periphery. So this pattern is seen in progressive massive fibrosis, as seen in co-workers pneumoconiosis. So I will inquire with the patient about any occupational history and review any previous radiographs if available.
So you said pneumoconiosis because of. Tell me the reasons you've gone down.
Because of the opacities in the bilateral mid and upper mid zones with a pattern of coalescing like conglomerate masses.
Okay, so think you've jumped a bit there. So you're right, there is upper to mid zone. Have you said the word fibrosis yet?
Yes, ma'am. Yeah. Fibrosis.
Yeah, so upper to mid zone fibrosis. So focus on describing that first so you can get all those points. You want to say the hyla are being pulled up and there is linear shadowing, and you're thinking that there is upper zone fibrosis here. Now you're thinking of all the causes that cause upper zone fibrosis. The coalescing, I don't see. You want to see more mass-like areas. You want to see dense consolidations that look like they're coalescing together to go down the PMF, the progressive massive fibrosis route. That certainly happens in pneumoconiosis, but I don't think I can convince myself that I see it here. I do see fibrosis, but that's pretty much it. But I do want you to, if I say, have a go at it again and describe how you would describe upper zone fibrosis. Give me all the points that you want to say. Talk about the mediastinum, the diaphragm, the lung volumes, all of that. Try it again.
This is a frontal radiograph of a mature skeleton. I see that there is fibrosis seen predominantly in the mid and upper zones. There is pulling up of the hilum bilaterally. There is flattening of the diaphragm. So this is a cause of mid and upper zone fibrosis. I'm looking for the causes like sarcoidosis. I'm looking for any hilar lymph nodes. Then tuberculosis. I'm looking for any apical opacities. Then another cause is radiation, but there is no pattern of specific pattern of involvement of radiation. Another cause could be ankylosing spondylitis. So I'm looking for any calcification of the interspinous ligaments, which I would like to window for appropriate seeing. And another cause could be drugs. So I will inquire with the patient for any history of drug exposure.
Okay, well done. That was so much better than the first time. So I'm going to give you the CT and see if you can narrow down.
This is a high resolution CT thorax showing the bilateral mid and upper zone fibrotic changes, which are showing honeycombing changes. There's bronchiectasis and honeycombing changes.
So when you want to say the bronchi are dilated in the context of fibrotic lung disease, you don't say bronchiectasis, because when you say bronchiectasis, it means primary bronchiectasis. So you want to say traction bronchial dilatation every time, yeah? So this is upper zone fibrosis with traction bronchial dilatation and honeycombing. Is there something specific about the pattern of fibrosis? Is it more anteriorly or more posteriorly?
It's more posteriorly.
Yeah. Do you know which disease does that?
Not sure.
Okay. Do you want to look at the lymph nodes?
I would like to look at the window, abdominal window, soft tissue window. So there are
not many, but a few calcified lymph nodes.
No significant lymph nodes.
Yeah. So you have a pattern of fibrosis that's quite typical for a disease. This is a posterior pulling of the bronchi. It's almost like somebody standing behind the patient and pulling the lung backwards. It's very typical for stage 4 sarcoidosis. And by stage 4, lymphadenopathy has usually resolved and you have a bit of calcification left. But the pattern of fibrosis, the posterior, this one, is quite typical for sarcoid. And if you see that, the expectation would be to think down the sarcoidosis route pretty quickly. And then the next question will be, what stage of sarcoidosis is this? And then, do you know the stages of sarcoidosis? Can you tell me the stages of etc., which I'm sure you do. So that's that one done. I'm going to move on to the next one. I'm going to try giving you a harder one, see how you do. So this one, don't worry about the diagnosis straight away. Just focus on going about it the right way. So this patient is in looking like they're in heart failure. So you have describe the X-ray for me first.
This is a frontal radiograph of the chest of a patient who is in heart failure. I see that there's no pneumothorax, pneumomediastinum, or pneumoperitoneum. I see there are multiple external leads and midline sternotomy sutures are seen. Then looking at the lung fields, there are prominent vascular markings. There is cardiomegaly, there is unfolded aorta. Looking at the bones are normal. And there is some haziness in the right lower zone, which could be due to effusion, which is tracking along the lateral chest wall. Cardiomegaly.
So, with congestion.
Yes, I think
so it's a typical heart failure chest X-ray. I just wanted to go through it with you to see how you approach a chest X-ray. So when you start with the chest X-ray, take a few seconds, pause about 5-10 seconds to take in all of it, and then have a little paragraph ready before you start. So this one you see straight away there is, a typical heart failure chest X-ray. So when you describe it, start from the lungs, start from the most obvious abnormality, and then don't start with the pneumothorax, pneumomediastinum bit, because that may be a thing you do in rapids maybe, but not in a VIVA description. Don't start with that straight away. I think it's one trick sometimes we use just to make sure we don't miss a life-threatening abnormality, but saying it doesn't seem as smart as we want ourselves to sound like. So this one is a heart failure patient with a sternotomy. But what this patient has, he has a abnormal echo, and he is deteriorating quite quickly. He has a previous heart surgery for a aortic valve replacement. Let's see if you can spot the abnormality. I'm going to slow it down a little bit. So one thing to remember is somebody gave you a cardiac case, we must be doing well. And I'm going to give you another reformat to see how you do with that. So I told you the patient has a aortic valve replacement, and the patient has an abnormal echo and is in heart failure. You see the heart failure changes with a bit of pleural effusion, some septal thickening. So focus on the heart.
There is left ventricular hypertrophy seen.
Mhm.
Is
The patient would have that anyway if they had aortic valve disease that was subsequently treated. That I'll give you a cardiac mag up view. So look at the aorta. Look at this view. That's one coronary. That's the other coronary. That's the artificial aortic valve. Then there's this thing.
There's an aneurysm arising from the what's this proximal portion of the aorta could be
What is that called?
a sinus of Valsalva aneurysm.
Yeah. Is it an aneurysm or a pseudoaneurysm? The first question. And how would you differentiate, if you can, imaging wise? And why do we want you to differentiate? So go down axial this way. You'll see again that this is the aorta. Then you have this pouch coming off it there. So you would describe that. If you see that, if you pick that, you would say the patient has an aortic valve replacement. There is an irregular appearance to the contour of the aortic sinus. I am suspicious for outpouching. Given the patient's previous history, this may represent, if you're thinking, I want you to think out loud, you're thinking this may represent normal post-operative appearance. I would be interested in looking at patient's previous history. Given the patient's symptoms and aortic valve replacement, I would consider asking the cardiologist to do an echo to look at possible aneurysmal dilatation of the aortic sinus. When somebody has surgery, when somebody has intervention, the kind of aneurysms they get after that are pseudoaneurysms because the wall is deficient. That's the difference between a pseudoaneurysm and an aneurysm. Pseudoaneurysm is quite weak, an aneurysm is quite strong because an aneurysm has all the walls and pseudoaneurysm does not. It is made because part of the wall was deficient, and that's how it was formed in the first instance. So I do apologize. I think it's a difficult case, but I wanted to throw that in so you can be aware you can get cardiac stuff in the exam. Something we don't actually keep in mind all the time. This one you should be able to pick. So this one again, try the style of chest X-ray that we just talked about. Describe it because you can see the abnormality straight away. Now all the marks are in the description.
The endotracheal, this is a frontal radiograph of the chest of mature skeleton. The endotracheal tube is appropriately positioned. I see that there is increased vascular marking seen bilaterally, and there so there are multiple nodules seen.
Yeah.
So this could represent again cardiac failure.
Nodules, cardiac failure.
No, I think they are vascular markings, prominent vascular markings.
Okay, so if you're saying all of these are end-on vessels and this is just pulmonary congestion, if that was true, why does he have a ETT and why are there no? Why is the heart not enlarged?
So this could be a non-cardiogenic pulmonary edema.
Okay. If what else can it be? You describe them as nodules. Let's stick with that thought. That they are bilateral nodules.
It could be miliary nodules, as in metastasis or due to infectious cause.
Okay.
Or fungal infections also could be.
Yeah. So ask the right questions now.
So I will correlate with if any previous radiographs were available. Also correlate with inflammatory markers.
Ask the examiner the history. You have to ask it before they offer it. Yeah, you would say, rather than say, may I have the history, you can say, I would be interested in knowing the history of the patient, and then you pause.
Mm,
And I would say, immunocompromised.
So this could represent a fungal infection, so pneumocystis carinii pneumonia. Sorry, this could be miliary tuberculosis in an immunocompromised patient.
Mm-hmm. What do you want to do next?
I would like to do a sputum AFP culture to
I'm a
confirm my
radiologist.
findings.
I don't have a sputum.
I will also do an HRCT of the thorax.
Okay.
On this HRCT of the thorax, I see that there are multiple ground glass nodules seen in bilateral lung fields. And some of these are is the central lobular in location.
Mm-hmm.
I do not see any tree in bud nodules, so this could be an endobronchial pathology such as
Such as endobronchial spread of infection.
yes.
You don't see tree in bud?
Um, cannot. Okay, yes,
That's the
there are
tree,
some.
and that's the
Yeah.
bud. Yeah.
There are some tree in bud opacities and central lobular also. So this could, in an immunocompromised patient, this supports my diagnosis of Mycobacterium tuberculosis.
Okay. And is that a reportable disease in terms of infection? Do you need to highlight that? Yeah.
I will immediately communicate these findings to this referring clinician, as the patient needs to be isolated till the anti-tubercular treatment is started, as the patient will be communicable in the interim.
Okay, perfect. Let's do one last one.
This is a lateral radiograph of the humerus of a mature skeleton. I see that there is a spiral fracture of the fibula of the femur. The bone, underlying bone, appears normal. I would inquire about the history, whether this was atraumatic, which is most likely
Minimal trauma.
So this is a pathological fracture. So I see that there's an underlying abnormality, which is a lytic lesion, which is having a wide zone of transition with the adjacent bone. There is no periosteal reaction. There's no large soft tissue mass. In this age group patient, I would like to know the age of this patient, as my differentials would be dependent on that.
65.
Yes. So at the age of 65, I would first consider a diagnosis of possibility of metastasis. A second possibility could be of of a myeloma. So I will review any previous radiographs to assess. Okay. I will. I would I would in consultation with the MDT, I would arrange for a biopsy of this lesion, which will be done by the sarcoma team, and follow up with an MRI of this limb, including the upper and lower joints, for assessment of involvement, local staging.
So when you said this could be a metastatic deposit or it could be primary bone, are these your two differential, bone tumor or metastatic tumor? Yeah.
Yes, yeah. Primary could be a.
Yeah. Primary could be some anywhere, or this could be the primary, because it could be a primary bone malignancy. Or so if this was a if this was a MET, what do you need to request before you go down the biopsy route?
I would do a CT thorax abdomen pelvis to scan for the primary, to evaluate for the primary.
Okay.
So there are multiple hepatic target lesions, could be metastasis. So I'm looking for the cause. A cause could be there's a ectopic.
Mhm.
The left kidney is mal-rotated.
Yeah.
The stomach wall is thickened, but it's undistended. The rest of the colon is. I would like to look at the lung windows for any pathology. Okay, the lungs are normal.
The lungs are
The
normal. Yeah.
lungs are normal. So I would still like to review the intestines, the colon specifically, as the hepatic mets could be
It's normal.
from there. So then this could be a multi.
Anything else you want to review other than
Okay,
the
there's
organ?
a speculated mass in the left mammary region. So a tiny speculated mass. So this could be a primary breast cancer. There is also a collapse of L2 vertebra.
Are you looking at this? I think that's nothing.
No.
It's just breast tissue.
Okay, there's a right
So you have.
mastectomy.
So let's go about it the right way. There's no mastectomy. I think it's just old patient. They're a bit asymmetrical. The breast tissue is normal. We're going to go back to the bone first. So when you see, nobody's going to show you a plain fracture in a VIVA unless there was something special about the fracture management or the location of the fracture. It's a typical mid bone fracture. It's not going to be a simple fracture. So that's one thing. If you pick the fracture straight away, you immediately need to start thinking about pathological fracture. They're not showing you a fracture, they're showing you something about the fracture they want you to talk about. So describe the fracture. Always say displacement, not displacement, stable, unstable, if that applies. It doesn't really apply here much, but you can say that there are cortical breaches on both sides. And you rightfully said there is a lytic lesion. Straight away you said the bone is normal, and then you said it's abnormal. Like I said, always with the fracture in a VIVA, there's something wrong about the fracture. It's not a simple fracture. Pathological fracture, the minute you pick a pathological fracture anywhere in a skeletal study, you have to say, I want the patient to have a staging CT to look for underlying primary. You have to say that. That's your first step. You have to highlight the X-ray report to the primary physician. You have to recommend a staging CT chest to look for underlying primary. You have to say that very clearly, straight away, and that makes you safe. So once you've done the CT, you have to go through the CT in a systemic way, and you have to say it out loud. You're going through. I'm looking for a primary. The lungs appear clear. Because don't be enticed by the clear abnormality you see straight away, because there's so many liver lesions. You want to start talking about them straight away, but I would say because you see the liver lesions, you should think, okay, so it is cancer. I was right. Don't focus on the liver lesions. They're not going to give you a liver lesion only scan. They want you to find the primary, and they want you to have a systemic way of thinking. So when you have liver lesions, but the lungs are normal, you're automatically, rightfully thinking GI tract. So you said colon. Unless it's a CTC, they're not going to make you look for a very tiny circumferential bowel thickening on a CT. It would be something more obvious. You picked the liver lesion. You did not talk about the necrotic looking nodes that were at the right next to it, and that's one. That's two. And you picked the stomach wall thickening. The minute you picked it, you should have noted that there were nodes next to it. And this patient actually did end up did have a esophageal primary with adjacent lymphadenopathy and the liver mets. You've picked one bone lesion. You forgot to say that I'm going to look for bone metastasis as well, because nobody's going to die from a pathological arm fracture, but they will get paralyzed from a metastatic spine. So this one here, you should be talking about, or if you can't pick it, you should say it out loud. I would like to exclude further bone metastasis. And this one, when you picked, if you had picked it, what would be the next step?
MRI of the spine.
MRI of the spine, yeah, rightful. So, what sequence would you like to see?
T2 weighted sagittal.
Okay. There you go. What do you, if you, this is on your reporting file, what do you want to do?
Yeah, I will immediately communicate these findings to the referring clinician as there is severe compression of the spinal canal, and I see that there is, yeah. So this patient needs urgent decompression of this mesh lesion.
Okay. Okay. Anything else about the bones? Any other mets you see?
I think the thoracic spine is normal. Cervical spine is also normal.
Okay.
There are modic and changes at lower lumbar level, but no metastatic changes.
Okay, well done. I'm just looking at the time. I don't want to eat into a candidate 4's time, so thank you. I will move on to candidate number 4, if that's okay. Did you have any questions about any of the cases that you want clear about?
No, thank you so much.
Okay, thank you. Candidate number 4, are you with us?
Hello, Dr. Reza. I think you'll recognize.
Hi.
I am presented with a frontal radiograph of the